All right, MCQ of the day and further continuing our discussion on hyperkalemia. जो first episode we had recorded, it was on hyperkalemia, and this time we are going to taking this one step further, going one step further, one MCQ at a time. So with the help of this MCQ, I want you to better understand the topic of hyperkalemia. Let's get started. A 68-year-old man, he is having a CKD, type 2 diabetes mellitus, comes for routine follow-up. Okay, no emergency problem. And he is taking lisinopril, metformin, spironolactone. ठीक है, ये दिया है. Serum potassium level 6.1. Normal potassium level क्या है? You should know that it is normal potassium level is 3 to 5, 3.5 to 5. ठीक है. This is the normal potassium level. So he is having hyperkalemia. The examiner is saying you that he is having hyperkalemia. He is asymptomatic. ECG is showing no abnormalities. Generally, if there is hyperkalemia, in the last question that we had discussed in the episode 1, I had given you the ECG abnormalities. Here there are no ECG abnormalities. Hyperkalemia is there, but it is asymptomatic. And so we have asked him to discontinue spironolactone, and he is doing dietary potassium restriction. But even after 1 week, his potassium is 5.8. Why did and his potassium now is sorry. Why does this keep happening? This his potassium is 5.8 1 week later. And so what we have done is we have seen that he is having high potassium, so we have told him to discontinue spironolactone and limit your potassium intake, but still there is high potassium. So what is the question is that what is the long term management? So what is the long-term management? See, we'll discuss this topic through this MCQ. So you give intravenous calcium gluconate. See, intravenous calcium gluconate is a good choice for treating hyperkalemia if there are cardiac abnormalities, and if there is you are suspecting that there is arrhythmia, the patient can go into arrhythmia, ECG abnormalities are there, then you your answer should have been calcium gluconate. But question में दिया है कि there is no ECG abnormalities, there are no ECG abnormalities, so no need to choose calcium gluconate, because see, calcium gluconate, what does it do? It stabilizes the heart membrane. I've told you this in the first episode also. It stabilizes the heart membrane. It does not directly decrease the potassium levels. Oral sodium polystyrene sulfonate. See, oral sodium polystyrene sulfonate, this was an old drug to treat hyperkalemia, and now we don't use it because it causes bowel necrosis. You hardly ever hear of this drug. And you give inhaled albuterol. Albuterol is a drug which we give for COPD and asthma, and there is a side effect of this drug is that it causes hypokalemia. So sometimes we use it to treat hyperkalemia as well. What does albuterol do is it will shift the potassium into the cell, and this is a good short-term treatment, but not a long-term treatment. You cannot give somebody COPD drugs and asthma drugs long-term. He does not have any lung problem. Okay. Now hemodialysis. Oral patiromer is the right answer, but I'll cover the wrong one plus. Hemodialysis is the last option which you have to treat hyperkalemia, especially in CKD patients. If nothing works, then finally we have to rely on hemodialysis. But here we should first try oral patiromer. Okay. So what is oral patiromer? The mechanism will understand today of this oral patiromer. But first, I want to ask you that why is he having hyperkalemia in the first place? Why should he have hyperkalemia in the first place? Because he is on this drug. He is on lisinopril. He is on spironolactone. So these drugs, they act on the kidneys, and lisinopril, it acts on the RAS. ठीक है? It acts on the RAAS, renin, angiotensin, aldosterone system, and these drugs are notorious to cause hyperkalemia. If you give just lisinopril, not that much of hyperkalemia. If you give spironolactone, not that much of hyperkalemia. But if you give them both and you keep adding other drugs, then there is more risk of hyperkalemia. So that's what the it's given in the question, that they have discontinued spironolactone and they have seen the results after 1 week, but still it's not going down. So what is this drug and why it is used, oral patiromer, why it is used to treat in the long-term management of hyperkalemia? We'll understand this today. See, here I have a diagram of the person's intestine, and this patiromer drug, it is a cation binder. Cations are plus charge wale जो होते हैं, they are cations like calcium 2 plus and sodium plus, Na plus, K plus. So this patiromer is a calcium binder. So you give the person oral patiromer. So he ingests oral patiromer. So this is the oral patiromer he is having, and it is not just patiromer, it is patiromer calcium complex. Okay, so there is this patiromer, and on the patiromer there is a calcium ion. Okay, and in hyperkalemia what happens is, in the intestine there will be K plus. This is the K plus. ठीक है, ये मैं K plus बताता हूँ. This is a K plus, and this is your patiromer, and if this is your Ca2 plus, what it's going to do in the intestine, it is going to leave this calcium and it is going to bind with this potassium. Matlab this will break with this and it will bind with this, and it will go down from the rectum into the feces. So it will cause wasting of potassium. So it is a good drug in the management of long-term hyperkalemia. It is a good drug in this kind of CKD patients who are on multiple drugs, and these drugs cause hyperkalemia, and we cannot stop these drugs because these drugs are used for his hypertension and CKD. So we cannot stop these drugs. So we give, to counteract the hyperkalemia which is happening, we give these drugs. Okay. So that was your MCQ of the day, episode 4. Hope these you are liking this series. Every day we are doing one short MCQ, and with that MCQ we are finishing up the one short topic. And I have also just finished recording a big lecture on acid base disorders, and first time I am wantedly trying to give as much as lecture in Hindi, because acid base disorder is a type of topic which most of the medical students find very hard and difficult to understand, and it's an important topic. It comes in your competitive examination. So I am hopefully going to post that episode to tomorrow. Today is Saturday evening. I'll upload it on Sunday morning. So my request to all of you, if you have watched this video till now, is that watch that video tomorrow, and you will clear your concept of acid base disorder. And Sunday, if you are going to enjoy your Sunday, watch that video and enjoy your Sunday, because you will be doing one concept and then enjoying your Sunday. So keep it as a Sunday to-do list, and like, share and subscribe to my channel, and thank you for watching.